Bismillahirrahmanirrahim. Today's lecture is about general organization of the kidney and urinary tract, and we will also discuss physiological function of kidney. General organization of the kidney and urinary tract. The two kidneys lie on the posterior wall of the abdomen outside the peritoneal cavity. These are the two kidneys which lies on the posterior wall of the abdomen outside of the peritoneal cavity in the flanks. Each kidney of the adult human weight about 150 gram and is about the size of clenched fist. If you will measure the kidney, it is about the size of the clenched fist. The middle side of the kidney contains an indented region called the hilum, through which pass the renal artery and vein. Lymphatic nerve supply and the ureter leave the kidney, which carry the final urine from the kidney to the bladder, where it is stored until emptied. This is the outer border or lateral border of the kidney, and this is the middle border. It is indented, and in this indented area of the kidney is called hilum, through which the blood supply, the artery enter in the vein, leave the ureter, and also the nerve supply is through this area or through this hilum. Kidney are the principal urinary organ of man and animal. Inner margin concave, outer margin is convex. This is the inner margin which is concave, and the outer margin, outerly, it is convex. The kidney is surrounded by a tough fibrous capsule that protects its delicate inner structure. You can see this is a capsule which covers the kidney. It is a tough core and it protects the delicate inner structure of the kidney. The kidney has two major regions, the outer cortex and the inner region, the medulla. This is the cortex, this is the outer region which is called the cortex, and the inner portion is called the medulla. The medulla is divided into multiple cone-shaped masses of tissue called renal pyramids. These are the pyramids. These cone-shaped structures are called pyramids. These are the pyramid-like structure which is present in the medulla. The base of each pyramid originates at the border between the cortex and the medulla. This is the base of the pyramid, and it originates at the level of cortex and medulla. The apex of renal pyramid, which project into the lumen of a calyx of the kidney, and through which collecting duct discharge urine. This is the tip of the pyramid, and it is called the papilla, and it ends in a funnel shaped structure which is called callus, and which is part of the major callus of the kidney, and in which these papilla ended, and then the urine is collected through these calluses into the major callus system, and then ultimately the urine passes to the ureter. Callus is a funnel-shaped continuation of the upper end of the uterus. This is the callus, which is the continuation of the upper part of the ureter. Border of the pelvis. The outer border of the pelvis is divided into open-ended pouches called major calluses that extend towards the renal medulla and divide into major calluses, which collect urine from the tubule of each papilla. These are the major calluses, and they extend into the medulla and make a calluses, and on which the papilla and empty its urine into the callus. When more than two calluses or two or more than two calluses combine with each other, they make a major callus, and then it empties into the renal pelvis, and then ureter is originated from this pelvis. The wall of the calluses, pelvis and ureter contain contractile elements that propel the urine towards the urinary bladder where urine is stored until it is emptied by the maturation. These calluses, the pelvis and the ureter contain contractile tissue which when contract propel the urine in downward direction to the urinary bladder where the urine is stored and then when at a proper time it is emptied. Each kidney contains 1 million nephron and each nephron is capable of with renal. The nephron is the functional unit of the kidney. Each kidney in the human contains about 1 million nephron capable of forming urine. This is a complete structure of nephron and each kidney contains 1 million nephrons. The kidney has no capability to regenerate new nephron, therefore with the renal injury, disease or normal aging, there is a gradual decrease in nephron number. The nephron number decreases with the age, diseases or injury. After age 40, the number of functional nephrons usually decrease about 10% every 10 years. Thus, at age 80, many people have 40% fewer functional nephron than they did at the age of 40. This loss is not life-threatening because adaptive changes in the remaining nephrons allow them to excrete the proper amount of water, electrolyte and waste products. So the remaining nephrons are sufficient for removing or performing the normal function of the kidney. This is a complete structure of one nephron. Here you can see that the renal artery enters into the kidney at the level of pelvis. It passes from the medulla and enters the medulla, and at the junction of cortex and medulla it is converted into an arc which is called arcuate artery. From this artery, branches are originated, entered into the cortex, and from each apparent arterioles a structure is formed which is called glomerulus. Remember this glomerulus top of capillaries. When this arteriole enter into the glomerular capsule or Bowman capsule, it anastomose multiple time and make a top which is called glomerulus. Remember this glomerulus, both the branches are made of arteries. Usually the apparent branch is artery and the apparent is vein, but in this case, in the case of glomerulus, both the branches are made of artery. Glomerulus capsule or Bowman capsule is made of single epithelial layer, and there is a space between the glomerulus and between the capsule. In this space, fluid is filtration occur. In this space, the filtration occur from the glomerulus into the Bowman capsule. On the other hand, the Bowman capsule is continued as a proximal convoluting tubule. This is the proximal convoluting tubule. This proximal convoluting tubule ends on the descending limb of a loop of Henle. From here, descending loop of Henle began. The loop of Henle has two limbs, the descending and ascending limb. The descending limb is thin and the ascending part of the ascending limb is also thin, but when it enters into the distance into the cortex, it has a thick part. So the loop of Henle has ascending, descending limb, and the descending is thin, part of the ascending limb is thick. Beyond the thick loop of Henle, the distal convoluting tubule started and they end at the collecting ducts. These are the collecting ducts. These collecting ducts in the cortex and medulla make single duct which is called collecting duct. These are collecting tubules, and the glomerulus contain a network of branching and anastomosis. Glomerular capillary, compared with other capillary, have high hydrostatic pressure, about 60 mm of mercury. The glomerular capillary are covered by epithelial cell, and the total glomerulus is encapsulated in Bowman capsule. This is the Bowman capsule. This is the glomerular top, and it is covered by the glomerular capsule, which is a single layer. As I told you in the previous slide, it is a single epithelial layer covering. It has apparent arterial and apparent arterial. Here a structure which is called macula densa, and also we have granular cell. These are the granular cell which contain the renin and mesangial, outer mesangial cells. We also have inner mesangial cells and outer mesangial cells. These podocyte, these are the podocyte cells, and these are the mesangial cells, and they keep the glomerular capillaries in positions. They keep them together, attached with the Bowman capsule and with each other. From the proximal tubule, fluid flow into the loop of Henle. When fluid filter from the Bowman glomerular capsule, glomeruli into the Bowman capsule, then it enter into the proximal tubule. Fluid flow in the loop of Henle, proximal tubule, then it flow in the loop of Henle. We dip into the renal medulla. Each loop of Henle consists of descending and ascending limb, as I told you, and the wall of the descending limb and the lower end of the descending limb are very thin, and therefore are called a thin segment of loop of Henle. After the ascending limb of the loop has returned pathway back to the cortex, its wall become much thicker, and it is referred to as the thick segment of ascending limb. Here it is a travel when in the ascending limb of macular densa. At the end of the thick ascending limb is short segment, which is actually a plug in its wall, known as the macula densa. The macula densa play an important role in controlling nephron functions. Here you can see that this is the ascending loop of Henle and thick loop of Henle. Beyond the thick loop of Henle is a short part of the tubule which is called macula densa, which pass in front of the Bowman capsule, where the artery enter and leave the capsule. This area is called the macula densa, and this macula densa, these are the actually plugging cells in this tubules. This apparatus is consists of the macula densa cell, the glomerular cell, the mesangial cells, and it is also called a juxtaglomerular apparatus. This structure is also called the glomerular apparatus. Granular cell contain the renin. Distal tubules. Beyond the macula densa, fluid enter the distal tubule, which in the renal cortex. This is the macula densa, and beyond this area is called the distal convoluting tubules. This is followed by connecting tubules and cortical collecting tubule, which lead to the contraction of collecting duct, which lead to the cortical collecting duct. This proximal tubule end in a tube which is called cortical collecting tubes. The initial part of 8 to 10 cortical collecting ducts join to form a single large collecting duct that run downward into the medulla and become the medullary collecting duct. When in cortex, 8 to 10 collecting ducts join with each other, they make a collecting duct, and which run into the medulla and become medullary collecting duct. The collecting duct merge to form progressively large duct that eventually empty into the renal pelvis through the tip of the renal papilla. All these collecting ducts combine together and make a single duct which is called collecting duct, and it empty into the papilla or the tip of the pyramid of the medulla. In each kidney there are about 250 of the very large collecting ducts, each of which collect urine from about 4,000 nephrons. Urine from 4,000 nephron. Regional difference in nephron structure. Cortical and juxtamedullary nephron. Those nephrons that have glomeruli located in outer cortex are called cortical nephron. They have short loop of Henle that penetrate only short distance in the medulla. These are the nephrons which glomeruli located deeply in the cortex. They are called cortical nephron, and they have short loop of Henle which enter the medulla for a short distance. About 20 to 30% of the nephron have glomeruli that lie deep in the renal cortex near the medulla and are called juxtamedullary nephrons. These are cortical nephrons and these are the juxtamedullary nephrons because they lie near to the medulla. These nephrons have long loop of Henle that dip deeply into the medulla. In some, these nephron cases are all the way to the tip of the renal papilla. Here you can see that these are so long that they reach to the renal papilla. The cortical nephron. The entire tubular system is surrounded by an extensive network of tubular capillaries. Here you can see that these nephrons are covered by extensive network of peritubular capillaries. When this arteriole when leave the common capsule, then it surround the tubules and make a mesh work which is called peritubulary capillary meshwork. So in cortical nephron there is an extensive peritubular capillaries are present. Juxtamedullary nephron long apparent arteriole extend from the glomeruli down into the outer medulla and then divide into specialized peritubular capillary called vasa recta that extend down into the medulla, lying side by side with the loop of Henle. So juxtamedullary nephron, when there is not such extensive mesh, but they make a long arteries, capillaries, and these long capillaries are called vasa recta, and they extend down through in the medulla, lying side by side the loop of Henle. These are loop of Henle and lying side by side the loop of Henle. Like the loop of Henle, the vasa recta return towards the cortex and empty into the cortical vein. This is specialized network of capillary in the medulla play an essential role in the formation of concentrated urine. Here you can see that emerge from the abdomen capsule. They run side by side with the loop of Henle and come back to the cortex, and they play a specialized role in formation of concentrated urine. Overview of kidney function. So physiological function of kidney are excretion of metabolic waste product and foreign chemicals, regulation of water and electrolyte balance, regulation of body fluid osmolarity and electrolyte concentration, regulation of arterial pressure, regulation of acid-base balance, and secretion, metabolism, and excretion of hormone, and gluconeogenesis. Function: excretion of metabolic waste product, so foreign chemical, drugs, and hormone. metabolites excreted by the kidney. The kidney are the primary means for elimination waste product of metabolism. These products include urea from the metabolism of ammonia, creatinine from muscle creatinine, uric acid from nucleic acid, and product of hemoglobin breakdown such as bilirubin and metabolites of various hormones. The kidney also eliminates most toxin and other foreign substances that are either produced by the body or ingested, such as pesticide, drug and food activities. So these are the main function of the kidney for removal of the waste product which are ingested or produced in the body during metabolism. Regulation of water and electrolyte balance. For maintenance of homeostasis, excretion of water and electrolyte must precisely match intake. The intake and excretion must be precisely match with each other. If intake exceeds excretion, the amount of that substance in the body will increase. If you take something more like drugs, food, and it is not excreted, it will accumulate or deposit in the body and its concentration will become increased. If intake is less than excretion, the amount of that substance in the body will be decreased. These two things may be in balance. If imbalance occurs, so the either one or the other may be increased or decreased in the body. The response of the kidney to sodium. When tenfold increase in sodium intake from a low level of 30 milliequivalent per day to a high level of 300 milliequivalent per day is taken within 2 to 3 days after rising the sodium intake. Renal excretion also increased to about 300 milliequivalent per day. A balance between intake and output is re-established. At first, when the sodium intake is increased, so the kidney doesn't respond for 2 to 3 days. So the sodium concentration increase in the body. But after 2 to 3 days, adaptation of the nephron or excretion power of the kidney balance with the intake and start increase excretion of the sodium. It come again to the baseline and the balance between the intake and output is maintained. However, during the 2 to 3 days of renal adaptation to higher sodium intake, there is a modest accumulation of sodium that raises extracellular fluid volume slightly and trigger hormonal change and other compensatory response that signal the kidney to increase their sodium secretion. Initially, in 2 to 3 days, when the kidney is not alert or adapt to secrete the excessive sodium, extracellular volume is increased initially for 2 to 3 days. But when the kidney become adapted to extra sodium from the body, the extracellular volume again become normal. It is true by the hormonal changes and increased excretory power of the kidney. This is also true for water and for most other electrolytes such as chloride, potassium, calcium, hydrogen, magnesium and phosphate ions. So if you will increase the intake of water or these electrolytes, initially there will be no response for 2 to 3 days, but ultimately become adapt with the increased concentration and start removing the extra amount of water or electrolyte from the body and bring the elements to the normal values. Regulation of arterial pressure. The kidney play a dominant role in long-term regulation of arterial pressure by excreting variable amount of sodium and water. The role of kidney is dominant in controlling the blood pressure by removing water and sodium. Kidney also contribute to short-term arterial pressure regulation by secreting hormone and vasoconstrictive factor or substances, for example renin, that lead to the formation of vasoactive product like angiotensin II. So in hypotension, the kidney release renin, which cause vasoconstriction, increase the blood pressure. So this is a regulation of blood pressure. The renin, angiotensin, aldosterone system increase blood volume and pressure. This is here. Angiotensin is secreted or made in the liver, and renin is secreted by the kidney. When angiotensin is released and when renin act on it, the angiotensin is converted into angiotensin 1. Then angiotensin 1 is converted in lung into angiotensin 2. Angiotensin 2 has direct and indirect effect on the vessel or on the blood pressure. The direct action is it causes arterial to contract, resulting in an increase in blood pressure, and decrease glomerular filtration rate, increase glomerular filtration rate, resulting in water retention, and it also increase thirst too, and a person take more water, and this way volume is retained. The indirect action is through aldosterone, release of aldosterone, and ADH, antidiuretic hormone. The aldosterone causes nephron distal tubule to reabsorb more sodium and water, which increase blood volume. So aldosterone causes absorption of sodium and water and increase the volume, and ADH mediate insertion of aquaporine into nephron collecting duct cells. As a result, more water is reabsorbed into the blood, causing arteries to contract. Regulation of acid-base balance. The kidney contribute to acid-base regulation along with the lung and body fluid buffer by excreting acid and by regulating the body fluid buffer store. Here the bicarbonate is taken into the blood and the hydrogen ion are excreted into the lumen and then removed through the urine from the body, and in this way take part in acid regulation of acid-base balance. Regulation of erythrocyte production. The kidney secrete erythropoietin, which stimulate the production of red blood cell. This kidney and it produce erythropoietin, which increase the production of red blood cells. One important stimulus for erythropoietin secretion by the kidney is hypoxia. When there is hypoxia, anemia or high altitude where oxygen concentration is low. So this is a predisposing factor for the production of erythropoietin by the kidney. When there is hypoxia, the kidney release erythropoietin. The kidney normally account for almost all the erythropoietin secreted into the circulation. Mainly the erythropoietin is produced by the kidney. In people with severe kidney disease or who have had their kidney removed and have been placed on hemodialysis, severe anemia develops as a result of decreased erythropoietin produced. So anemia, hypoxia, kidney produce erythropoietin, and erythropoietin act on bone marrow and produce RBCs. But when there is damaged kidney or kidney is removed and a person is on hemodialysis, he develops severe anemia if exogenous erythropoietin is not given to the patient. Regulation of 1,25-dihydroxy vitamin D3 production. In skin we have 7-dihydrocholesterol. When the sunlight convert it into pre-D3 or 25-hydroxycalciferol, and when this is added to the skin vessel and transported to the kidney, and in kidney it is converted into 125-dihydrocholecalciferol, and this 125-dihydrocholecalciferol is active form of vitamin D, or it is called vitamin D3, which is responsible for the deposition of calcium in the bone and reabsorption of calcium from the gastrointestinal tract. Glucosynthesis, the kidneys synthesize glucose from amino acid and other precursors during prolonged fasting, a process referred to as gluconeogenesis. When there is prolonged fasting, the kidney also usually glucose is produced. Gluconeogenesis occur in the liver, but when there is prolonged fasting, gluconeogenesis also occur in the kidney. The kidney's capacity to add glucose to the blood during prolonged period of fasting rival that of the liver. In prolonged fasting, glucose or glycogen is converted into glucose or gluconeogenesis occur in the liver, but it is a rival to the liver. Kidney in fasting condition. The kidney also start gluconeogenesis. With chronic kidney disease or acute failure of the kidney, these homeostatic functions are disturbed and severe abnormality of body fluid volume and composition rapidly occur. When there is damage to the kidney, all these functions are deteriorated and there is imbalance in all these components. With complete renal failure, enough potassium, acid, fluid and other substances accumulate in the body to cause death within a few days unless clinical interventions such as hemodialysis are initiated to restore at least partially the body fluid and electrolyte balance. So in disease condition or in case when the kidney is removed, hemodialysis is necessary or important to keep all these things in balance. Physiological anatomy of the kidney. See you in the next lecture.